Good evening, everybody. Diabetic Foot Society of India welcomes all of you to their fourth webinar, and we are very happy to have Professor Robert FRYKBERG from Phoenix. I think as Dr. Robert is again, all of us are very familiar with Professor Robert FRYKBERG, and he started his undergraduate education in 1969 and did his uh, podiatric fellowship in 1973. See, I was actually born in 1974, so his experience is my age actually. So he did this DPM and followed that with Masters of Public Health from the Harvard University. He is the former chief of podiatry section of the Phoenix Veterans Affairs Medical Center in Phoenix, Arizona, and is medical director of the DM Prevent Diabetic Foot and Wound Center in Dubai. He is an adjunct professor at the Midwestern University program in podiatric medicine, and he is a former chair of the Foot Care Council of the American Diabetes Association and is a past president of the American College of Foot and Ankle Surgeons. He was the 2011 recipient of the prestigious Roger Pecoraro Award from the Foot Care Council of the American Diabetes Association. His research and writing interests have included all facets of lower extremity disorders, but specifically focused on diabetic foot ulcers, infections, Charcot foot, and wound care. So he has been the editor of two textbooks, The High Risk Foot and Diabetes Mellitus and The Diabetic Charcot, and he is the author of more than 100 peer-reviewed publications. Professor FRYKBERG is currently a director of the Association of Diabetic Foot Surgeons and is a fellow of the Faculty of Podiatric Medicine of the Royal College of Physicians and Surgeons of Glasgow. I think all of us will be aware of the Sanders and Freiberg classification of the diabetic Charcot foot, which talks about the anatomical location of the Charcot foot. And again, he was also part of the group which brought out the classification of diabetic foot surgery along with Professor David Armstrong. Now I welcome Professor Robert FRYKBERG to start his lecture on surgical approach to the diabetic foot syndrome.
Okay, thank you, Rajesh. You'll let me know if there's any problems here. Welcome, everyone. It's a beautiful early morning here in Phoenix. I'm happy to be with my friends again in India. I probably have met a number of you at my 5 previous trips to India years ago, and I believe I'll be coming back this December at your annual meeting. Dr. Kesavan and Dr. Bal had asked me to speak to you on surgical approach to the diabetic foot syndrome. Recognize that unfortunately, as Rajesh had said, I've been in this field for a long time. And 40 years ago, surgery on the diabetic foot was not a routine practice because it was misunderstood and people questioned operating on a diabetic foot because it was expected that they could not heal. Luckily, we know much more now than we did back in the early and mid 1970s. So I want to give you my overview and my perspective on this discipline, and hopefully it'll be of some use to you. So is surgical management of the diabetic foot a new concept? Not at all. There's really nothing new under the sun. This was from the Bible and Ecclesiastes. That which has been is what will be, and that which is done is what will be done. And there's nothing new under the sun, meaning that people have been operating on the neuropathic foot, let's say, for many, many years. If I can get my computer rolling here. In the pre-1950 era, you had some very seminal publications being done by the McKittrick brothers out of Boston, out of the Harvard system, where they published their landmark paper on the transmetatarsal amputation that many of you might be aware of. And that was at one point called the diabetics operation because this was in the days pre-revascularization, and there was no hope for the ischemic foot or forefoot. And so TMA became quite popular. In the 1950s, we saw more reconstructive or localized surgeries being performed, as we can see here. Kelly in Coventry, Martin in England, Parsons and Norton's as well. And in fact, the Martin paper on neuropathic lesions came out of King's College Hospital in London. So we started to see more interest in local management, local surgical management of the diabetic foot as we gained a better understanding of the neuropathic nature, more so than the ischemic nature in those days. And then, of course, in the 60s, we had the very famous papers by Eichenholz, where he gave his classification for the Charcot foot. J.T.H. Johnson with a wonderful paper on neuropathic fractures and injuries. Paul Brand, who practiced there in Vellore, India, talking also about the Charcot foot, and Coventry and McCook and others dealing with surgical management of the diabetic foot. Then, of course, in the 1970s, we had Marv Levin and Lawrence O'Neill, who published the first textbook on the diabetic foot by that name, and several other persons publishing their experience on surgical management of the diabetic foot. So in the 1970s and late 60s, this was really born and started to become more and more popular. And then finally, in the 1980s, we saw a new growth of procedures. We had in the mid-80s, Leventon's procedures on plantar exhaustectomy in the Charcot foot. Several of us from the Deaconess Hospital in Boston had published our experience on surgical management of diabetic foot. And of course, there were several others important publications as well. In the 1990s, we saw an increase in growth of publications. And I think, as you'll see, the rest is modern history. Now, I can't keep up with all the surgical papers on the Charcot foot or the diabetic foot, whereas many years ago, they were few and far between. It was quite easy to keep a handle on all the papers being published. But now I think you'll agree that the discipline has literally exploded, and foot surgery in the diabetic patient has become far more commonplace than it was before. Although I still dare say that it's somewhat misunderstood, and I believe that people need to have a full appreciation for the complexity of the diabetic foot prior to entertaining any surgery. Now, I've used this graph for years. Excuse me, I've got allergies, so I'm sniffling here. This cartoon or graph, however you want to call it, algorithm, just shows the various underlying pathophysiological parameters that are abnormal or can be abnormal in the diabetic foot, diabetic patient in the diabetic lower extremity. Obviously, neuropathy is our main underlying risk factor for most of the things that we'll be talking about. Neuropathy is the key risk factor for almost all diabetes, lower extremity related problems. But that's not just sensory neuropathy, it's also motor neuropathy, as well as the all-important autonomic neuropathy with the loss of the underlying neuroregulatory responses, the triple Lewis flare response, etc. We also recognize the important role of vascular disease. I understand last week you heard from my good friend Cal Suresh on managing vascular disease. But remember, vascular disease is not just macrovascular disease with atherosclerosis. It's also microvascular disease, in part caused by this neuroendocrine disturbances due to autonomic neuropathy. So this sets up a high-risk foot system, as we can see here. And when you apply trauma to that foot by by wearing an improper shoe, or by stepping on a nail or a tack, or walking barefoot and sustaining blisters or burns. With the impaired response to infection, you can get an infected diabetic foot ulcer, and when untreated, this becomes gangrenous, infected, and requires amputation. Now, over here, we're talking about the role of motor and sensory neuropathy causing deformity, abnormal pressures, high plantar pressures, and callus formation. And this leads us to our discussion of deformity, which is really critical in the diabetic foot. But first, I think it's important for us to realize this causal pathway that can lead to amputation in a diabetic foot. And this comes from my friend Lee Rogers, where we published in 2010 a supplement to the Journal of Vascular Surgery dealing with diabetic foot problems and surgery. So at the bottom of the stairway or so, you have the neuropathic, with or without PAD, the high-risk foot, which is susceptible to injury. And that injury could be walking on a callus that goes untreated, or walking barefoot, as we see in my part of the world, where you can sustain second and third degree burns from a 5-minute walk barefooted. And I'm sure this could be the same in your part of the world as well. So then that injury progresses to a chronic wound, especially when it's improperly treated. Then that wound can develop infection, and then infection can lead to gangrene, which will require amputation at some particular level. So these are the general causal sequences that lead to amputation. But as you can see, there's many opportunities for prevention of amputation along this pathway by stepping in early, by making an early diagnosis, and intervening early. This is an important and simple way to look at the diabetic foot. This came from Gail Reiber's paper in 1999, Diabetes Care. And it's really took the Pecoraro paper on causal pathways. It was published in 1991, and then on amputations, and then applied it to causal pathways leading to diabetic foot ulcers. And what they found here was that 63% of the causal pathways that led to foot ulcer had this triad in the causal pathway of neuropathy, deformity, and trauma. And of course, neuropathy is the key here. Now, and you can see the 7 putative risk factors in the box on the right, but neuropathy is key, as well as neuropathy, as well as trauma, and of course, deformity. And when you put those 3 component causes together, you will almost invariably obtain the outcome of interest, which in this case is diabetic foot ulcer. So this goes to show us the importance really of deformity, which could be just high plantar pressures, hammer toes, simple deformities, but also the applied trauma to that neuropathic deformed foot. And so it also gives us a measure for not just the etiology, but also how to prevent these problems. So a simplistic approach based on the Ken Rothman model, but still very, very insightful. So this gets us back to our structural deformity, which we recognize that any deformity can lead to high plantar pressures and subsequent ulceration in the neuropathic foot. And so when we look at structural deformities, we know there's primary or idiopathic deformities which pre-exist neuropathy or diabetes, like bunion or hammer toe, very simply. A secondary deformity would be an intrinsic minus foot, those that are secondary to neuropathy. And we know the intrinsic minus foot is claw toes, depressed metatarsals, loss of intrinsic muscle stability with long flexor over dominance, anterior crural atrophy, foot drop, equinus deformity, and even this is where Charcot deformity comes in because it's secondary to neuropathy. And then we have the iatrogenic deformities, which really are due to prior surgeries. As we can see, you lose a great toe, then we recognize that the second toes, the second and the lesser toes can often become hammered, or we see ulcers on a remaining high pressure point of when one leaves one ray behind, which is really what we do not want to do. So iatrogenic deformities are very common, and also we have to expect those and therefore practice a good deal of prevention if we're to prevent those complications. Now, I'm not going to go over this graph too much. This also comes from the Hingorani Journal of Vascular Surgery Clinical Practice Guideline published in 2016, where we're looking at patient presents with diabetic foot ulcer and how it requires adequate assessment to properly understand the underlying problems at hand. So obviously vascular assessment here is always key, as well as looking for infection, and that's why we probe our wounds. We always get our x-rays, at least our imaging always becomes an x-ray, because we don't know if there's bony erosions, fractures, gas underlying that, what have you. So by doing a good thorough vascular assessment, by doing your imaging and your infection assessment and looking at that wound, we can classify that wound by University of Texas or PETUS or SADSAT or however else, excuse me, the SINBAD system or the San Elian system, however you like. And then we know that we must approach our therapy with debridement, offloading, wound bed preparation, medical management, and surgery. Surgery is often necessary, but not always. It's always necessary when there's underlying ischemia. At least we need to consider the role for angioplasty or for open surgery. But when you have an infection, obviously, we need to do surgical debridement and surgical incision and drainage. Now, if we don't do surgery, then we reassess after 4 weeks and see if the wound has progressed with the magical 50% healing. If it has not been healing properly or has not reduced a significant amount in 4 weeks, we need to go back and reassess, and then oftentimes just reconsider the need for surgery. I think in years past, too many people were too hesitant to do surgery when surgery was really indicated, i.e. when you have an exposed metatarsal head. I think it's very unlikely when you're looking at cartilage of a metatarsal head that you can expect that to adequately heal with conservative offloading and care. I think when cartilage is exposed, in my experience, most often that cartilage needs to be removed. I think it's just a harbinger for bacteria. So my bias is if I'm looking at bone, I'm expecting infection of bone. And so I want to resect that bone. And that doesn't mean amputations, but it can mean a metatarsal head resection or a joint resection or a partial resection. But I think we need to be more aggressive in terms of our foot-sparing surgeries than we had been in the past, because it's going to lead to faster healing rates. So treatment of the ulcerated foot in 2020 still has not changed for the last 2 decades. Remove or correct the etiologic cause. Medical management is concurrent with our wound care. Vascular assessment and revascularization to restore a pulse is always indicated as necessary. Look for infection and treat the infection. Wound care consists of wound bed preparation, debridement, offloading, and dressings. And of course, I'm highlighting the role of foot surgery here, whether it be curative or versus ablative foot surgery. And again, we cannot emphasize enough the role of prevention of recurrent ulcers after healing, because these people are at the highest risk for recurrent ulceration. And that's where prophylactic or reconstructive surgery comes into play. So what are the surgical indications for the diabetic foot? Obviously chronic diabetic foot ulcer, infection, gangrene, osteomyelitis, but also difficult deformities, post-partial foot amputation, Charcot foot, or even an unstable Charcot foot, generally of the rear foot or ankle. Very common indication. If we look at this picture right here, we can see that underlying metatarsal head and cartilage that's exposed. Now, for me, that's an obvious indication for surgery, where I'll even go right in through that ulcer and I'll remove the metatarsal head through that ulcer if need be. And recognize also, many times if you have recurrent ulcerations, despite good care, prevention care, offloading, the recurrence and recidivism is due to those high plantar pressures due to that residual structural deformity, more often than not an iatrogenic deformity. Okay, so a lot of good indications for surgery on the diabetic foot. Now, originally, we had classified diabetic foot surgery way back in 1994 in Steve Kaminsky's textbook. And then Dave Armstrong and I revised that and just modified it a little bit in 2003 into these 4 types of procedures. A elective procedure would be those reconstructive procedures in a non-neuropathic patient. Let's say a new onset diabetic with a pre-existing structural deformity, primary structural deformity, where they had since they were adolescent. However, more commonly, we're talking about prophylactic surgery, which we define as a closed wound in a neuropathic patient, either in a patient who has not yet ulcerated or who has ulcerated and healed. And this is the ideal time to intervene in these patients. If a patient has undergone several bouts of ulceration, has healed, recurred, that's a good indication that this patient needs underlying surgery. And it's always less risky to operate on people with a closed wound, obviously, than with an open wound, although closed versus open does not stop us from doing surgery. So our curative classification would be an open wound and an effort to cure that wound. Now we say to get that wound into remission, but we use the term curative, where the surgery is used as a curative procedure to affect healing of that wound. And then, of course, emergent would be those procedures performed to arrest progressive of infection. And there have been some very nice papers out of India on the treatment of acutely necrotizing soft tissue infections, necrotizing fasciitis, etc. But this is those cases where you can't afford to wait, because the emergent surgery is life-saving as well as limb-sparing. So these are our general classification schemes. And this subsequent paper also by Larry Lavery, who did this with us, showed that recurrences at 1 year and infection postoperatively rise, as you would expect as you move from elective up to emergent types of cases. That's pretty self-explanatory, but it just goes to show, as I said, it's far better to perform a reconstructive procedure either at the elective stage, pre-neuropathy, or certainly in a neuropathic patient when the wound is closed or before it ulcerates. So what are the typical elective or prophylactic procedures, class 1 and 2? Hammer toes repair, metatarsal osteotomies, plantar exostectomy for a healed Charcot foot ulcer, bunionectomy, tendo Achilles lengthening, very commonly done, when carefully done, can be a very nice procedure. And it usually is done in conjunction with other types of procedures as well to address that chronic equinus. Charcot reconstruction, I think always safer to do a Charcot reconstruction in the class 2 prophylactic stage when the ulcer has resolved, if and when possible, and we know that that's not always possible. And sometimes also amputation for a severe deformity, severe Charcot ankle can, sometimes amputation is the best bet for a patient who just has failed prior stabilization procedures. Curative surgeries, class 3, would be pretty much the same types of operations, except the operations are done in the presence of a open wound. So our types of operations are not mutually exclusive when we talk about elective, prophylactic, or curative, because it's all done according to the setting that we're in. And commonly, your curative procedures, metatarsal head resections or joint resections, Keller Arthroplasty that we'll talk about more, plantar exostectomy for an open Charcot midfoot ulcer, commonly, partial calcanectomy we've all done for a chronic heel ulceration. Tendo Achilles lengthening is also often done to cure a forefoot ulcer in the presence of severe ankle equinus, a very simple procedure that can sometimes be effective. So obviously curative surgery indicated for Wagner grades 1, 2, or 3. No, on my previous trips, hopefully I can turn this down. Sorry, my previous trips to India, I have talked about this. My favorite operation is the Keller Arthroplasty for hallux ulcers, and I'd like to turn the sound off on this. Let me know if you can't hear me. Just hopefully it'll be okay. Keller arthroplasty is my favorite procedure. Very useful for those ulcers under the great toe, which is one of the most common locations for the great toe when bone's not exposed. This is an old operation, published I think first in 1909 by William Keller, and it's resecting the base of the proximal phalanx of the great toe, as you can see here, to affect increased motion. Because remember, many of these diabetic patients have hallux limitus or functional hallux limitus, which is structural, meaning that they have a restricted dorsiflexion on that great toe. So that when they walk, when the pressure is applied to the base of the great toe, I'm going to just turn this off while I'm explaining it. When they apply pressure to the base of the great toe, it loads that foot, and the functional hallux limitus causes a restricted dorsiflexion of that great toe. And therefore, a Keller bunionectomy is a very easy way to allow for an increased motion of that great toe. Here I'm going to show you once again where we are dorsiflexing that hallux in a non-loaded position, and it moves just fine. I'm sorry, let me go back here. I'm sorry. If we try dorsiflexing the great toe, non-loaded position, I guess I'm just not going to work here. I'm sorry about that. Here we go. We load it and it moves wonderfully. We load the bottom of the foot, pressing on the metatarsal, like in weight bearing, and look how the restricted motion occurs in the great toe. That's what happens with functional hallux limitus, and that's why the Keller arthroplasty is a wonderful way to surgically correct that problem. Now, some people have tried tenotomies in that, but in my hands, a Keller arthroplasty, resection arthroplasty, removing the base of the great toe is a wonderful way to effect a cure for those hallux limitus, not conditions and plantar ulcers not involving the bone, meaning there's no osteomyelitis present. Okay, so let's move on here a little bit. This is the TMA. I can do a whole lecture on TMA, and I'd rather not do that at this point. But this was popularized by McKittrick in 1949. It's been used for ulcerations in the presence of severe forefoot ischemia, forefoot sepsis, osteomyelitis, multiple gangrenous toes, prior partial foot amputations where you're left with a single, let's say, ray and digit, as we saw in one of the pictures before, or where there's you need to affect primary closure for a difficult wound. Many different needs for this operation. And that's why McKittrick and my colleagues at the Deaconess Hospital in Boston always called it the diabetics operation, because it was so useful. And I'm sure many of you rely on this operation very, very commonly. Now, I'm a purist about this operation because I trained where it was really developed. Although the McKittricks didn't really, weren't the first people to use this operation or publish it. They're the first to publish it in a large group of diabetic patients. So this operation was really perfected in the Deaconess Hospital in Boston. And so it's a very, very, very useful procedure in a number of circumstances to close some very difficult wounds, and it's functional afterwards. Patients can walk without formal prosthesis, only with a closed shoe and a custom-made orthosis. So it's very good. And the healing rates, though, between 50 and I go up to 80%, because you have to expect complications after these operations, because these are complicated patients and complicated problems, complicated deformities. But when done properly, and followed up with good preventive footwear and preventive care, it works out very, very well. The typical incision is a long arced plantar incision is distally, you can make it possible right up to the sulcus of the toes, and then a transverse incision right across the top. So my preference is always to do a long plantar flap and meet it at the top incision, never a long dorsal flap unless you really have no other plantar tissue, because obviously the plantar skin is going to have a lot more fat, it's going to have a lot more cushioning, it's far more durable. And many people will do a concurrent tendon Achilles lengthening at the same time. I do not do that unless there is a pre-existing equinus deformity when I'm performing this operation. So I'm presuming that most of you have done a TMA on a regular basis, many papers on TMA, and it's a very, very good operation. And then we get into rear foot amputations, Lisfranc, Chopart, Pirogov, Boyd, or Syme. Chopart is probably done most commonly, and I've done more of those than most of the other rear foot ones. I've never done a Pirogov or a Boyd. I think it's foolish to put hardware into a neuropathic foot that's infected, as these require, but some people do it very effectively. So I think we're all well aware of the Chopart's amputation, whereby we are really just taking the forefoot off, really right at the mid-tarsal joint at the talonavicular and calcaneo cuboid joint, with a long plantar flap to effect a primary closure. And a very good operation, but this also requires a concurrent Achilles tenotomy, because you'll develop a very severe equinus deformity postoperatively if you do not do that concurrent Achilles tenotomy. So the Chopart's is reserved for extensive tissue loss of the forefoot, osteomyelitis of the forefoot or midfoot, gangrene of the forefoot. And I've used it very effectively for very severely impacted forefoot infections and tissue loss. And it's a fairly effective operation as long as you do that Achilles tenotomy concurrently. You must do that. And rather than a tenotomy, a lot of people will take a small section of tendon, a tenectomy, because we know that if you do not do that, that patient will develop a rather severe equinus deformity. This operation, of course, always requires, though, a formal prosthesis, patella tendon bearing prosthesis afterwards, because of the loss of stability in the foot and the inability to wear a shoe if you don't have that, because there's no forefoot. So you really do need a prosthesis with a built-in forefoot. And these people can do very well as long as they heal properly and don't have recurrent wounds. But many times I'm doing these on people who have residual ischemia, where they had inadequate reperfusion of the forefoot. And so you might have some difficulties with wound healing. But all in all, a pretty successful major amputation of the foot. Now, one of my other favorite operations that's not often done around the world is a Syme amputation, described by James Syme in 1843. His first patient was a young man with tuberculosis. It's not done often because it's not taught very often, and really it's a disarticulation of the foot at the ankle. And it's not done also because a prosthetic fabrication is more difficult. But I've used this, I guess I've done about 85 cases. We published a paper in 2007 on this as well. However, the indications are for chronic forefoot and midfoot infections, recalcitrant osteomyelitis of the midfoot, not really infection of the heel or ankle, but of the midfoot. Extensive gangrene of the forefoot, not suitable for a TMA, extensive tissue loss, severe deformities with ulcer instability and or infection. And this I've done for midfoot Charcot as well. Severe forefoot ischemia with adequate perfusion of the rear foot, and trauma and tumors. These are all common indications. And remember, tumor was the initial indication by Syme himself. Mickey Pinzer in 2003 discussed his Syme one-stage technique, whereas William Wagner promoted a two-stage technique where you take off the foot at the ankle and at one stage, and then go back in and resect the malleoli at stage 2. Well, there's a saying in America that says, you know, get out of Dodge as fast as you can. And so while the going's good, I want to get out of Dodge. So I'll always do a one-stage procedure here. And here's our general incision, very close to the ankle joint, at generally just at the talonavicular articulation, or just proximal to the talonavicular articulation, going, pretty much going straight across the ankle on the top, or a little curved on the top, and then straight down the medial and lateral sides of the foot, straight down, leaving a good heel pad. So you can't do this in the presence of any heel ulceration, but any forefoot ulcer is fine. Remember, the flap is actually the heel in this regard. And then you're by removing all that content of bone, the talus and the calcaneus, you have enough room to swing that flap up and suture it on the anterior surface of the ankle, especially after you've removed the two malleoli, as you can see here. So this is the typical look of, it should be of an x-ray. I tend to round these edges off a little bit. And here's the lateral view, and you can see sewing the plantar flap up into the bone because you don't want to have a loose flap. Now I do have a video here. Rajesh asked me to put in some videos. So I'm going to do a few individual shots of a Syme, because I'm sure many of you haven't seen a Syme amputation before, but I think you need to consider it because it's a way to preserve a leg. And these people can walk fairly easy on these stumps. So here is the incision. You can see I've already resected the forefoot at a previous operation to rid the patient of infection. I'm going straight across, just distal to the ankle, and then coming straight down the sides of the foot, as we showed you in the previous graph. Hopefully you can see this. So the two medial and lateral incisions are straight down the sides of the foot, connecting that first anterior curvilinear incision. I'm going to move over to our second panel here. Here you can see me resecting that. I tend to resect the entire forefoot or residual midfoot at that talonavicular calcaneocuboid joint. So it's really the initial resection is going to be the same bony resection as the show part joint, except I have resected all of plantar skin as well, or that plantar skin is already gone, depending on your circumstances. I like to do it this way in stages rather than do it all at one time. So you can see the incision straight across the ankle, going right down to the talar neck at the TN joint, and then resecting the calcaneocuboid joint as well, and then taking that foot off on block. Okay, and here we've gotten the forefoot off. We're looking at the talar head here, and we're tying off the vessels. Obviously, you've got to look for the posterior tibial and the dorsalis pedis anterior tibial artery, and tie those off. And hopefully you do have those arteries present, because prior papers have indicated that without that posterior tibial artery being patent, you're going to have a failure of this operation. I'm not sure that's 100% accurate, but you want to take your time at this point to get good hemostasis, because otherwise you'll have a bloody mess, and you don't want to have to go back in and tie those off after the fact from a bleeding vessel. Here you can see me taking off the talus. So as I said, I take the forefoot off. Then my next step is to resect that talus from the talocalcaneal joint and the ankle articulation. And obviously you have to be very careful here, especially on the medial side, because at this point you're going to have possible damage to the posterior tibial artery, and you don't want to do that. So you have to be very, very careful. So I'll use a heavy elevator to get underneath and use a combination of blunt dissection, as you can see, as well as sharp dissection to just really resect that talus from the bed on the dorsal calcaneus, as well as resecting it from the medial and lateral ankle, and just being careful not to puncture through the back of the ankle. And with care, you can do this. This, however, is not the hard part. You can see me using the big, I call them graspers. I think they're peons or something. And I grab that talus and try to resect it. It takes care. This operation you'll find probably more difficult than a baloney amputation because you're working in a very tight area. However, I'm sweating a little bit throughout that, but that's not the worst part. This is the worst part here. Resecting the calcaneus from the plantar bed, and here you can see me using a blunt, large dissector to remove the soft tissue from the posterior portion and the medial, lateral, and plantar portion of the calcaneus. Now, the hardest section is the posterior, obviously, because the Achilles tendon attachment is there. And it takes a good deal of effort and care to get that off without puncturing through the posterior skin envelope at the back. I've only done that once or twice. A resident did it once, and I never forgot it. So it's very important. You really have to be careful. This is where I really sweat. So it amounts to a good deal of tugging on that calcaneus, lifting it up while you're carefully dissecting from the heel pad and the surrounding soft tissues. But it's very difficult, and this is where I sweat the most. And you don't want to obviously injure the medial vessels as well. But once you get that out, you breathe a sigh of relief, because it does take a lot of careful dissection to get that out, using a variety of instruments to do that. And then once you do resect the calcaneus, you next proceed to move on in this next panel to resecting both the medial and lateral malleolus, pretty much flush with the joint. I'll usually do a little bit of a flare, but not too much of a flare, because you don't want that plantar flap to be flopping around too much. So you almost would rather leave the resection square rather than too much angled, and that's been my experience. So here I think I'm removing I can't tell whether that's a medial or a lateral malleolus in this panel, but you want to resect them both, being careful not to penetrate or rip the skin flap, because these corners of the skin flap can be very easily disrupted. So you don't want to do that. That's both the medial and lateral flap. So once that's done, your bony resection is done, then you'll usually flush it. Now, what I'm not showing you here, I'm going to turn these other ones off. But what I'm showing you here is using the plantar flap, and tying it into the anterior calcaneus. Okay. I use bone anchors now. Previously, we just did 2 drill holes from the anterior tibia through the plantar, right through the joint space. A medial and a lateral drill hole, so I can effect a non-absorbable suture through the bone, and then coming out into the plantar fascia and tying it so that you would keep it tight. Now I just do a bone anchor medial and a bone anchor lateral, and then I use the attached fiber wire or Merceline or whatever the stitch is, and suture the plantar flap to that. So here we can see we're trying to effectuate a healing, taking that flap and suturing it in. Okay, so it requires your assistant to be holding that flap in proper position for you while you're tying that. And I try to make it as tight as possible, because you do not want a floppy heel pad. You do not want a floppy heel pad. So you want to make that fairly snug. So it's requiring suturing that plantar pad or the plantar flap that you're rotating up, the heel pad, and I usually suture it into the plantar fascia that might remain there. And you do that on both sides, and then you'll put a drain in. And here in this next panel, we can see just the final suturing here, and you can see that the drain has already been placed. And I just use this. Some people close with Vicryl subcutaneous tissues. I tend not to. Once I get that heel pad tied in to the tibia, I tend not to put a lot of subcutaneous stitches in, absorbable or not, because I don't want them spitting. So that's basically the procedures. I'm sorry if that wasn't clear, but those are just the individual panels showing the techniques involved in doing this operation. Very good operation. Here's the end product where you can see the drain coming out above. We use a small tube low suction drain. That should be your stump. The medial and lateral flares or dog ears, as you see, just resorb. I tend not to do anything with them and let them resorb. Here obviously is the specimen. Here you can see the incision plantarly, and then we just put it all back together again. And this is what your x-rays look like. Now I don't tend to take so much off there. I would do more of a less of a flare, maybe down to here. And you can see the just an anchor here and an anchor there, and those anchors are in the tibia. So that's basically what it looks like. These are the patients walking with the prosthesis, and you can see they're doing pretty well. Here's what the prosthesis looks like in this panel, and these patients really just had gotten their prosthesis, and you can see this man is dancing on his prosthesis. This panel down here, I just applied the prosthesis for the first time on this man, and he got out of the chair and started walking with it. So that's the difference. You really don't need a lot of rehab here. You have to be careful your prosthesis is good, that your limb doesn't shrink and that, and it needs some adjustment, but it's very little difficulty and energy expenditure for a SIME amputation compared to a below knee, and it does preserve that leg. And remember, these are patellar tendon bearing prostheses. You can go back to that Water and Perry and Waters paper in Journal of or Bone and Joint Surgery. I think it was back in the late 70s, early 80s. They talked about decreased energy expenditure with a SIME amputation compared to a below knee amputation, obviously. So a very useful operation in the given circumstances, and I've used it quite effectively. And of course, your emergent surgery. I don't want to go too far with this because I know I'm running out of some time here, but I did want to go over these important things. We're all well aware, especially you all in India, are faced with emergent surgery, necrotizing fasciitis all the time. When you're faced with gas gangrene or ascending necrotizing infection or a foot such as this one, you'll know that you have to get that patient to the operating room as quickly as possible. And I refer you to the Vaz and Mike Edmonds and Vino Karaparthu's paper in 2018 on the diabetic foot attack. It's too late to retreat, meaning you've got to take care of these right away. And you're all aware of that. And these are typical emergent surgery cases. I'm not going to belabor this. They require a great deal of debridement, drainage of all infection, looking at all tissue planes, wide open incisions, and then learning to manage those wounds thereafter. Obviously, for all these procedures, there's numerous complications, infections, incision, dehiscence, gangrene, amputation, DVT, pulmonary embolus, pulmonary atelectasis, pneumonia, and other complications that we're all aware of for any surgery depending on the patient, which is why when you can, in these neuropathic patients, do the procedures under local anesthesia or local with sedation. There's no reason for general anesthesia for most of these cases. I think it's unnerving to do a SIME amputation or a below knee amputation or major amputation under local with sedation. But if that patient is snoozing while they're doing the operation, it's far safer using regional anesthesia than general. So that was always our preference. I don't want to go too far with this because I know I'm running out of time. Forgive me, Dr. Kesavan, but I did want to refer you to this paper that we published in 2011, looking at surgical site infections after surgery in diabetic foot. Now, as you would expect, you're going to get more diabetic foot infections after surgery. You're going to get more infections after surgery in the diabetic population compared to the non-diabetic population. And this was in 1,400 patients. That's what you would expect. But the question is it diabetes that's causing this problem? Is diabetes itself the risk factor, or is diabetes hiding something that's the more important risk factor? And of course, when you adjust your analyses, which you always must do, when you adjust for important risk factors like PAD, renal failure, neuropathy, then the true story comes out. And so when we looked at persons without diabetes or uncomplicated diabetes meaning those diabetic persons who did not have neuropathy or who did not have peripheral arterial disease or any major complications, you can see that they had very similar rates of surgical site infection after non-infective surgery here. However, when you put neuropathy into the mix with complicated diabetic patients, you see that this is really the driving factor. It's that neuropathic diabetic that causes the diabetic patient to have that increase in surgical site infection. So the main confounder for the diabetic patient is the neuropathy. If you take out the neuropathy, the diabetic patient is at no greater risk than the non-neuropathic, non-diabetic patient. And we've shown that also. So again, neuropathy is the key there. So if you have a diabetic patient without neuropathy, you treat them as you would a non-diabetic patient. If you have a diabetic patient with neuropathy or a non-diabetic person with neuropathy, i.e. Hansen's disease, leprosy, treat them the same as you would a neuropathic diabetic patient because they're more likely to have infection. So, in summary, for these types of surgery, I think is a key component of care. It's complementary to conservative care. I'm sorry, I'm going the wrong way. It's complementary to conservative care and often is very, very important to consider earlier rather than later. This should be performed at an opportune time in a medically stable patient with adequate perfusion and, if you can, no infection. And we're talking about the reconstructive procedures, not the emergent procedures. They can be performed not just within 1 week of revascularization. I've performed many of these immediately after revascularization, and it's just fine. I think the important point is careful management post-operatively and good post-operative follow-up. And remember the importance of protective footwear, foot care, and the multidisciplinary management, because I think that's all critical for the long-term success. Now, I was going to do a couple of case studies, but I think I'm running out of time here. I'm sorry I got a little bit long-winded. So I think, Dr. Kesavan, I'm going to hold this off now, and I'm going to let you do our question and answer period. I'm sorry if I was a little bit long-winded, as we say here, or long in the tooth, but I wanted to give you a good overview of my perspective on both acute and chronic reconstruction of the diabetic foot. So I'm going to stop my sharing here now, Dr. Kesavan, and I'm going to let you take over our controls. So I want to thank everybody for putting up with me this evening or this morning, as the case may be. It's always a pleasure to speak with you, visit with all my good friends there in India, and I hope I'll be seeing you in the next portion of this year. So thank you very much. Rajesh, I'll turn it over to you at this point.
So that was a wonderful presentation. Thoroughly enjoyed your presentation. Again, a lot of basic things that we had to know, we had to learn. Again, many times we tend to learn it the hard way. I think many of the newer people who are interested in diabetic foot, I think they will have a very good edge because they are learning from the masters. I think let us go on to the questions. One question from Dr. Saravanan from Madurai. Madurai is in South India. So I think he enjoyed your video on Symes amputation. So his question is, while doing Symes amputation, after removing the calcaneum, after trimming the tibia, I am left with a long plantar flap. While I bring it forward, the heel pad is getting placed more anteriorly. How to avoid?
Now, it's a, obviously, as I said, the Symes amputation is not done a lot in the world. My center probably did more than 95, 99% of the centers in the world on Symes amputation. It's rare to find someone with experience with more than 75 or 50 or even 25 Symes amputations, because it takes a lot of care and experience. But it's an end-bearing amputation. And as I said, with the Waters and Perry's paper, and you want to go back and look at it, it's an old paper, but looking at energy expenditure and oxygen consumption. As you go more proximal, the rates of oxygen consumption and energy expenditure increase. But with a Symes, it's significantly less than with a below knee amputation. So the patients can walk easier with a good prosthesis on this. It's an end-bearing stump. So some people say, well, you can use this stump to walk barefooted if you have to. I always caution my patients not to, because you don't want that floppy heel pad stump. But I had those same concerns, but I've never had the problem with a plantar ulceration under the heel pad, because you still have enough of that fat pad that you're walking on. And remember, you're not letting these people walk barefooted very much on this. You always want to encourage them. You must use your prosthesis like a below knee prosthesis. It's just a lot easier to walk on it. So you're bringing that plantar flap forward, but there's still enough fat pad underneath that. Remember, the plantar fascia is pretty much underneath. So it's surprising, and it's a good question. But remember, this operation has been time tested. It's not a new operation. And I think if you do it in the proper circumstances, it can be effective. You know, if a patient is non-ambulatory anyway, then it makes no sense. Okay. Unless you want to do it under local anesthesia. And I've had a patient where I had to do this under local anesthesia because anesthesia wouldn't touch the patient. And it's very easy to do an ankle block and do this operation. Okay. And I've done it on people who were immobile, but so sick that anesthesia was hesitant to give anything for them. So it's an easy operation to do. I think it's less invasive than a below knee amputation, but it's harder to do. There's no doubt it's harder to do. You have to be very, very, very careful. So your first one, take your time on it. Usually it would take me about 65 minutes would be the time period for this operation, because I didn't rush through it. Okay, but important points: careful calcaneal dissection, releasing that Achilles tendon, and tie in that plantar fat pad, the heel pad, into the anterior tibia. Okay, you want that so it's not moving around too much.
And another question related to this, again, where will you take the stitches for the plantar flap? See, you said you will be anchoring to the tibia, but where will you take the stitches in the plantar flap?
No, that's why I think I said that several times. I use an anchor which goes from the anterior tibia, and then I'll use the stitch and go on the inside, so I'm catching the plantar fascia. Okay, because that plantar fascia is good tissue, good firm tissue, and then I'm tightening that up and bringing that up to the anterior surface of the tibia. You know, you're talking right above the joint line now here, so we're not going way up the tibia, and that's firm tissue, and you want to tighten that and tie that in. Maybe if you want, you can do 1 or 2 absorbable stitches for the remainder of the anterior flap, tying it to the anterior skin of the ankle, but that's it, and it works out very well. So my suggestion is always catch that stitch. If you're not using an anchor, you're doing a drill hole, and your suture is coming from the joint surface of the tibia, coming into the plantar fascia, and then up to the anterior surface of the tibia. Okay, and making sure it's tight. You don't. The biggest problem is if you have too much fat tissue or too much plantar pad tissue, it's going to flop around too much. You didn't take enough skin off the plantar pad. So then you have to go back in and trim it, because that's not what you want. My suggestion is do your planning carefully. Sometimes you think, uh-oh, I've taken too much skin off the plantar pad. My incision was placed too far proximally. That medial and lateral incision generally right in line with the medial and lateral malleolus. That's the guide. And when you take those two malleoli off, it's surprising how much easier that flap can come up to the anterior tibia. So I've never had a problem where I couldn't close it. I would just resect a little bit more off the tibia if I had to. Okay. So experience will teach you that. The first one is a little unnerving, but you know, you guys are all experienced surgeons, and I'm sure it's not going to be any difficulty. Just, I put that in because I wanted some controversy, because most people don't do this operation. And I found it to be very successful. In fact, my vascular surgeon used to say, can't you do a SIME operation on this patient because I'm worried about them, et cetera, et cetera. So I've done a number of them.
This is one question from Dr. Rajiv Kumar Singh from Mumbai. Do you prefer gastro resection or TA lengthening with TMA amputation? Two questions in this. Again, would you prefer a gastroc recession or a TA lengthening? The other question is, would you do it in the same sitting as a TMA amputation? Or would you want to wait and do it off?
Okay, good questions. Common question. You know what? Some people love the gastroc recession. I found the percutaneous triple hemi section to be very, very easy without problem in these people. You know, if you're dealing with athletes, I think maybe a gastroc recession is more important, but I do the triple hemi section. I started out doing a Z lengthening in the old days, but now I do a careful triple hemi section when necessary. Careful not to rupture that tendon later on. Remember, Per Holstein's paper from the early 2000s showed he was very high on doing TALs until he had a few ruptures and then calcaneus deformities, and then he stopped doing them. So you have to be careful. The question about, do you do it at the same time? As I said, I think you do it when there's an equinus present, or when you can't get dorsiflexion greater than 90 degrees. Many people, however, do this operation at the same time. But for all the TMAs I've done, I have to say it's been a minority of cases where I've had to do a concurrent TAL or had to go back at a remote time and do a TAL because of recurrent ulcers of the forefoot or of the remaining distal stump. So it's a matter of preference. You know, you'll find preferences both ways. My preference was always not to do it unless I felt it was necessary to do it at the time. And doing a percutaneous triple hemi section is a very easy operation to do as an outpatient, as you know, if you need to do it down the road. So I don't think it's mandatory. It's mandatory to do a tenotomy or a tenectomy of a show part amputation, but it's not mandatory for a TMA.
A related question. In a neuropathic DFU, after a 4-foot surgery like midhead excision with TAL, after a few years, if the patient comes back with the same site recurrence, will you do a repeat TA lengthening procedure?
Remember, there's a paper by Michael Muller. Gosh, I can't remember the year, but I think it was in the late 2000s, maybe even 2004, where they showed that when you do a TAL, you get more rapid healing of an ulcer, but over the course of time, the equinus kind of recurs, I think. And that's an old paper, and I think it bears out clinically that I've seen the same, especially for a triple hemi section in that. So if equinus develops, I would just do a repeat procedure or a gastroc recession, whatever your preference is, or an open Z lengthening, which is what if you're really unsure, you need a good deal of lengthening and want to be sure that you have a good repair, do an open Z lengthening. And I did a sagittal, it was a sagittal plane or a transverse plane Z lengthening, where I have an anterior and a posterior section, so I could slide them and make sure I sew them back together again. So it's a matter of yes or no, what's happening, but also my first thing I'd want to look at in that recurrent situation is there residual osteomyelitis? Is that the reason for the blowout? And I think that's far more common, unless there's been a regrowth of bone, which could be as well, or enough bone wasn't resected at first. So, you know, as we all know, the diabetic foot is a multi-splendored entity, and you have to think of a lot of different things for it, biomechanically, as well as perfusion. And so you have to look at Achilles equinus, you have to look at infection, you have to look at mechanics. Was there adequate offloading? You know, many times these recurrences are due to people not paying attention to the preventive footwear, which is critical. Who's most likely to ulcerate? A patient who's previously ulcerated or has a previous amputation. So these are all very important things that have to be considered on every patient.
And one related question to this, again, if you do you find the same amount of recurrence of equinus after gastrocnemic recession?
Frankly, I was never, I've done gastrocnemic recessions. I never looked at it exactly for that, and you have to look at the literature for that. I don't think that's the question so much. But I think you probably can get recurrences either or. People who are gastrocnemic recession proponents were going to say it's less likely, I think, but it's not universal. So you take it as it comes. What's the difficulty if you have to repeat it years down the road? These are pretty simple operations. So I don't have any good data to say yes or no, or which is more common. But I say you have to look for it over the course of time anyway. It's more common that there's going to be some restriction of dorsiflexion down the road, regardless of what you do.
Dr. Atul Sule from Jabalpur, Madhya Pradesh, which is in the center of India. Your experience with posterior tibial nerve decompression.
Of what? Posterior tibial nerve. You mean
tarsal tunnel.
Tarsal tunnel. I hate tarsal tunnels. I hate tarsal tunnel operation. I call it no man's land. I get very nervous down there, although I took a course on tarsal tunnel surgery. I think two things. When necessary, it's a good operation to do. I think there were people who just like doing tarsal tunnel releases and nerve releases, and they were doing them without good indication. Now, the question is, does it improve neuropathy itself? Nobody's shown me adequate evidence to say that. It's been a big point of controversy. Does it cure everybody who has painful neuropathy? No. Does it prevent people from having forefoot ulcers or forefoot amputations after having done with it? Well, if you ask Lee Dellon, who's the biggest proponent of this, he'll say, absolutely, I can prevent recurrent ulceration. I improve sensibility. I reduce amputations. I don't think there's enough data on it, but let me say this. As I said, in the diabetic patient, when it's necessary and you think there's a discrete compression of the nerve resulting in a painful neuropathy along the plantar surface of the foot, I think it's certainly necessary. But to look at it as a cure for plantar neuropathy is really untested at this point. And it's an operation that doesn't always work, although it does work when it's really necessary. And of course, you have to be careful because it's a bloody area that you're working in, and but you have to get into that portopetus. And if you don't get into that constricted portopetus, you're not doing anybody any good. But again, to me, that's no man's land. That means I want to get in there and get out before I do some damage. So that's just my bias, my preference. I just never liked that operation, although I've done a number of them over the years.
A question on Keller's. what are your advice, or what is your advice to prevent shortening of the first toe of the hallux for a killer?
Not taking off too much bone. There's no need to take off half the proximal phalanx. Okay, that's the biggest problem. And thank you for asking that question. Keller operation has been around for over 100 years. It's one of my favorite operations because it's so easy and so effective. But what I've learned after doing over 1,000 Kellers is that you don't take off too much. And those of you who know the anatomy intimately well recognize that about 1 centimeter distal to the joint surface, there's a little prominence on the dorsum where really the capsule attaches. I use that prominence as my landmark for where I'm going to do the resection, and it's usually only about 1 centimeter or so resection. Okay, that's the key. If you take off 2 centimeters of bone, you're going to have that floppy toe, too short. You're always going to get some shortening, obviously. You want to make sure you do a good capsular repair as well, where I tie in that capsule back into the great toe so that I maintain some position. Some people will tie the flexor tendon into the bottom of the great toe. Some people got really fancy. I never got really fancy. I just made sure I didn't take too much off. Now, also the other thing is some people put a K-wire through just to maintain position and stability for a while. I tend not to for an ulcerated patient because I'm always worried about driving infection in there. I don't like hardware in the presence of an open wound, although some people do it without any problem. And I dare say when I've had to, I've done it without any trouble. But the key to the answer to the question is don't take off too much bone. And 1 centimeter or so should be your guide point. Now, sometimes if you take too little off, there's not enough motion. So you have to go back and take a little bit more off, another millimeter or 2 off. But never take off 1/3 or half of that phalanx. That's sure to fail. Then you're sure to get you a big floppy toe, and there's no propulsion available any longer. Okay, so I would not do that. But after many years and 1,000 procedures or so, that's still one of my favorite operations because by the time you remove the sutures, that ulcer is healed, and that's within 2 or 3 weeks. So it works. It works.
Your experience, say if a patient has a functional hallux limitus, would you prefer a medial plantar fascia release or would you go for a Keller?
I personally go for a Keller, but there is a paper, I think it was Tamir years ago, Tamir, I'm not sure, where they were talking about a plantar tenotomy, flexor tenotomy. You can try those other things. In my hands, Keller was sure and it worked. And it's a simple operation, local anesthesia once again. Minimal care, and 2 weeks they're healed. And I know for sure that ulcer is going to heal. A medial band, plantar fasciotomy, I'm not so sure that's going to work. Maybe a plantar or flexor tenotomy might work, but it's not going to decompress that joint. Keller will decompress that joint, even just taking out that 1 centimeter, because it's evident immediately after surgery. So my bias, and I'll call it a bias, is just to do the Keller. Okay, it's time tested for me.
And on again, tendoachilles lengthening. No, sometimes, rarely, the patient can develop a calcaneal gait if you overcorrect that. How often have you seen this? Second question is the calcaneal gait. How will you manage that?
Only when a tendon ruptured, and it was, frankly, I can't recall a patient where they ruptured and developed the calcaneal gait. I've had, I think, some partial ruptures and they were pretty loose, but never a calcaneal gait. I think that's a very difficult problem, and that's when you start thinking in the appropriate patient of a fusion of the ankle. Okay, very difficult. You can try tendon repairs, posterior tibial tendon resections or posterior tibial tendon transfers and that to get them out of equinus. But very, very difficult deformity. And anybody who's dealt with that, I'm sure knows that can be a big, big problem. And I think a lot of people in that situation would try to do some type of a fusion, maybe a talocalcaneal tibial, a tibio-talocalcaneal fusion, just to get that out of that severe deformity, because that calcaneus deformity is a very severe complication. You can try lesser things, I guess, repairing the Achilles tendon and that, but it can be a very severe problem. And a fusion sounds good to me in that case.
One question from Dr. Taudam Hemachandra Singh from Manipur, which is in Northeast India. What will be your protocol of wound management in order of priority?
For what?
Wound management.
Well, a surgical wound, or I presume it's a surgical wound?
No, it's for a diabetic foot ulcer.
Okay.
A little away from the topic.
No, that's the topic. The priority is, as I said, those basic tenets of care, which haven't changed in decades. I've been using that slide for decades and just changing the year. For wound care itself, it's always got to be debridement and then offloading, okay? But I think even more, equally important is determining the cause of it and ameliorating or removing the cause. You know, if and these seem very simple, basic, but not always followed through. You could never let a patient leave your clinic who comes in with an ulcer. You can never let that patient leave with the same shoe or sandal that they came in with. It's probably caused it. You just cannot do that unless it's an offloading boot or something. So removing the cause is critical. Debridement and obviously offloading. But you can't disregard the importance of proper, thorough assessment, looking for ischemia, probing that wound to see if it probes the bone, or looking for infection that might be underlying it, looking for ischemia, looking for bony prominences, looking for gas that might be going up the leg, looking for undrained pus. I mean, there's so many attributes of it. That's why you do a systematic assessment and a systematic approach, looking for each one of these things. But where the failures come, people not offloading properly, not detecting underlying osteomyelitis, or not detecting that unrecognized ischemia because the patient is asymptomatic. Okay? So you have to look for these things on every single patient. And frankly, I don't think this is a difficult discipline that we're in. It just requires understanding and a systematic approach to treating it. So that's about as basic as I can make it, because all these attributes are very important. But how can you correct a problem that you haven't assessed, right? That's my thing. So the good thing about classification systems is that it forces you to look for the components underlying that classification, like looking for bone involvement, looking for depth, looking for ischemia, okay, looking for infection. And that's the value of it. So, you know, I like a Wagner. Wagner's easy for me to remember, but I'm also looking for ischemia and infection. I mean, it's very simple. And to me, if you just say it's a Wagner 3, an ischemic Wagner 3, okay, I know what I have to do, okay? Or a non-ischemic Wagner 3, okay, it's fine. But, you know, sometimes people want the University of Texas or the PETUS or the Sinbad classification or the SAD classification, whatever it is. So, or San Elian, if you're my friend Fermin Martinez from Mexico. But University of Texas is probably the most popular. I think, though, in some cases it can be difficult because you need a wall chart because there's 16 different cells that you need to put that foot into. So that's why, for me, okay, it probes the bone and it's ischemic. I know what I have to do. I've got to look for osteomyelitis. I've got to make sure there's no infection, and I've got to get that ischemia corrected. It's that simple. That's why doing the systematic exam, you can use whatever classification scheme you want, but it's going to alert you. These are the problems, and you have to correct each problem that you detect. but you can't detect it if you don't look for it, okay? And that's just my view of this whole thing. We don't need to make a simple problem or a simple discipline much more difficult than it needs to be. Yeah, these are complicated patients. The diabetic foot can be a complex system, but not so complex if you understand it, okay? You always look for neuropathy, what level of neuropathy. You'll always look for the circulation. You always look for infection. You always look for deformity, and you correct whatever's there. So it's not that difficult to treat. And failures come by not recognizing underlying problems. That's why after 4 weeks, if you're not being successful, it's time to go back, and it's time to reassess. What have you missed? Or what is the patient not doing that they're supposed to be doing? Or does that patient need surgery now? Should I get another diagnostic imaging study? Because maybe I missed underlying osteomyelitis. Or you know what? I just got an ABI on this patient. I didn't get a pulse volume recording or a TCPO2, and that normal ABI is actually elevated, falsely elevated to a normal ABI. That patient is actually ischemic, but because I didn't diagnose that ischemia because I never got toe pressures or a toe brachial index, or I never got a PVR seeing a dampened waveform, and I never got a TCPO2 showing that there was only 20 millimeters of mercury going to that forefoot. So it's understanding all the various parameters and looking for them and addressing them. So I'm sorry, I don't think this is that difficult. Sometimes it's difficult to affect a good healing and you're wondering what's going on. But you have to look at nutrition, you have to look at all these various parameters, you know. And I guess we could talk about that for hours. So that's my perspective.
One related question from Dr. Patel from Asarwa, Gujarat, which is West India. How much time do you wait before you operate on a non-healing ulcer? How much time? Again, when do you say it's a non-healing ulcer? What will be the time duration to say it's a non-healing ulcer?
That's a good question. I'd say, you know, almost always, you want to try some good conservative care. In the absence of infection now, in the absence of osteomyelitis, okay, you always try good conservative care. Always, always, always. And I guess I do believe in that 4 weeks, 50% rule, although I'm not bound to it, but it's a good general rule. But if I see that an ulcer just is not getting better, despite good care, I've looked for infection, there's no ischemia, I had that patient even in a cast, I've even might try advanced therapies, which we have freely available to us here. I wouldn't hesitate to operate if the patient was suitable. Remember, a lot of these patients are sick. So if it was a younger, healthier patient with recurrent ulcers, I'd operate right away. Many patients, they come into me with a hallux ulcer that they've had recurrently for on and off for 6 months, 8 months, a year or so. I'll operate on them as soon as I can. I mean, it's not emergent, but I'll operate on them earlier. If it's a patient with a first-time ulcer, without complication, I'll give it a good trial of conservative care. I mean, I'm not here to promote surgery always. You always try good conservative care. You always try good prevention care. But despite our best efforts, many of these patients are going to recur or fail to heal. And then I think it's better to intervene sooner rather than later for the appropriate patient. As long as you recognize, you know, they're not ischemic, and if there's no infection underlying them. You know, if there's infection, operate earlier rather than later. Look at Falia's paper in 2006. The more you delay, the longer you delay, the more tissue you lose. Okay? So
Time is tissue.
there's no set rule on this, except the rule is try conservative care first when you can, when there's not an emergent situation. And then you discuss it with the patient, you know. And because we know, I believe I also said, complications can be common. So you don't want to intervene so soon that you create a complication that's worse than the problem. So that's also the scenario you have to keep in mind. You know, somebody can die from a simple surgery that like a Keller Arthroplasty, if they've got a bad heart and you operate on them way too soon and you didn't evaluate them properly, and then they die. Well, which is worse, the death or the ulcer that takes longer to heal? So We always keep these things in mind, obviously.
Sir, I think as we are coming to the end of time, I'm going to the last question. I think we have a lot more questions coming in, but still, I will make this the last one. One Dr. Kadabaman from Salem, Tamil Nadu. I think his question is, he has a patient with gangrene of 4th, 5th toe with ascending cellulitis. He's asking whether decompression of anterolateral compartment is enough, or would you decide on an amputation?
No, if they had gangrene, right? He said they had gangrene in the part of the toe. You take off the toes and you make sure you drain all underlying infection. My rule of thumb was, while I'm doing step A, I'm planning step B and step C at the same time. So I'm going to take off those gangrenous toes. You're going to have to do it anyway. And by leaving an open amputation, you're providing for drainage. Then the next step is, do I need a plantar incision more proximally or a dorsal incision more proximally for more drainage, or do I need both? And then what that's doing, a linear incision, when you can get by with that, is very easy to manage and easy to close without losing a lot of tissue. But remember, it's urgent when you have infection. Surgery is not adjunctive. Antibiotics are adjunctive. You need the surgery to drain the infection. So I would say amputate those toes, make sure you've drained enough proximal tissue. Okay. Remembering that you're going to want to do a definitive procedure once the infection is controlled and resolved. So you don't want to indiscriminately remove excessive amounts of tissue when you can avoid it. Okay. So plan step B and C while you're doing step A. That's always been my motto. Keep in mind what you're going to have to do the next step and the next step after that. And then you'll be far more successful in minimizing the amount of tissue that you have to remove. But always remove what you have to remove. I mean, that's a lesson also. If it's infected and dead, take it out. But if it's not dead, try to work with it.
And I think Professor Robert FRYKBERG, that was an excellent presentation. Again, an introduction and even a detailed learning for all of us on surgery as far as diabetic foot is concerned. Very extensive lectures on, again, sessions on Keller as well as Symes amputation. I would like to thank you for joining us in Diabetic Foot Society of India's 4th webinar. Thanks a lot, Dr. FRYKBERG, for this opportunity.
You're always welcome. Thanks for having me, Rajesh. Always a pleasure. And hopefully I'll see you all in the future. And let me say this. They call it a practice of medicine and surgery because you never get it right. So you're always practicing, right? That's why they call it a practice.
Yes.
Right? And I always call it a practice. So with experience, things become natural, second nature to you. Sometimes it doesn't work, but you instinctively should get to know, as soon as you see that patient, I'm going to have to do this, and this, and plan your course accordingly. Okay, I've said enough. Thank you very much, Rajesh. Thank you, everybody, for your attendance, and we'll see you again in the future. Thank you.
Yes, sir. Thanks a lot, sir. And
Okay,
before closing, I think I would like to invite all of our Diabetic Foot Society members for the next webinar, which is going to be on the next Saturday, the coming Saturday. It's going to be on peripheral neuropathy in diabetic foot pathogenesis. The speaker is Dr. Ashu Rastogi from PGIMI, PGI Institute of Medical Education and Research from Chandigarh. Dr. Aarti Shade from Pune will be the moderator. Thanks a lot for joining us. Thank you again.